We're going to move over to Roger Barranco, and Roger, you also come from a very unique perspective in the sense of you do both body and neurointervention. For me personally, looking at the radial space, I think the neurointervention is something that really has taken off in the last year or two. And from my own perspective, I think it seems to have some advantages that are very similar to the cardiology space, particularly in cases where you either heavily anticoagulating your patients for whatever reason, or you're doing complex procedures where you've got a lot of anticoagulation on board. So, what made you start working from the radial for neurointervention?
So we started back in 2015.
Yeah.
And the main reason to start is it's easier to start. I mean, why? We have all the huge experience from the cardiologists.
Yeah.
That they are working by our side. They are a friend of us. So we knew that the access, it was feasible. We already knew that.
Yeah.
To start neuro at the beginning, at that time I couldn't imagine that we would be treating stroke from radial access.
Yeah.
At that time, we just wanted to improve. In neuro, we treat a lot of patients for aneurysm. We do long-term follow-ups, and many times those patients are not ill patients, that are just patients that are, and they hate going to the hospital and have to do repeat angios. So at that time, we know that we could do the access, and at the first cases, cardiology helped us to do it. So the only concern for us was to be able to catheterize.
Yeah.
I mean, to be able to do it. And the reason why I started, I just checked from some papers, some literature. There was not a lot of it, but there was a very good paper from Korea back from 2010, and they had experience for more than 1,000 diagnostic procedures.
Wow.
And it was interesting because they were doing it from the right radial, and they were showing their success for catheterizing from right to left. So what I learned from them, that catheterizing the right carotid, I will go in order.
Yes.
The left vertebral was almost 100%. Right carotid was a very good success. For left carotid, it was a little bit lower. And for vertebral, for them, at their hands at that time, was 50%.
Coming from the right.
Coming from the right at that time. For diagnostic, we are talking just about diagnostic at this point. So at that time, we knew that, okay, these people have done 1,000. They were using Simon's 2, Simon's 1. Let's start. So what we did at the beginning is, of course, go step by step. So at the beginning, we decided that we had to do some follow-up of aneurysm, and it was a right carotid, just one vessel angiography. So I told the patient, okay, we have a lot of experience with the femoral, but if you are okay, we will try it from radial. Maybe we can, but we'll try. And surprisingly, we always said that to patients, but for the first 50 patients, we were able to catheterize.
Yeah.
So it was progressive, right? So we started for one vessel, then we moved to 2 vessels, and at the end we start for 4 vessels, even 6 vessels. For those ABM, ABF, you need to study both the externals as well. So you can do it from radial, and of course there's a learning curve.
Yeah.
And even talking to people that very experienced neurointerventional radiologists, they're saying, well, why going from radial? Because from femoral access is direct. But we can imagine when neuroradiology started in the 70s, the first angiographies were done direct carotid puncture. So it's still more direct.
Yes.
So regarding radial, we have all the knowledge, all the background for cardiology, and now with all these evolving techniques like snuffbox puncture, distal puncture, use of ultrasound, all these things that is coming and has improved the technique. But now I think we know in the last years, at least many centers worldwide, they are doing radial. We know that it's possible to do it.
Yeah.
So the availability and the possibility to do a 4 or 6 vessels angiography from the wrist, it's possible. So, and this, I think we are lucky because before moving to complex interventions, that can be like very nice to show, okay, I did this difficult case through radial. But doing the angiography, that at the last, you need to categorize not just one vessel, many times it's at least 4 vessels, gives you all the abilities. This is where you really learn. Yeah. And in a patient that it's stable, it's coming from home, so you have time to do it. And I think it's a good progressive way to do it. Of course, you don't need to take 2 hours, it's not fair. Yeah. But at the end, just do 1 vessel, 2 vessels, and for that you learn, and not only for the operator skills, also for all the team. How to do the room setup, prepare all the cocktail, everything. This is a really good way to start.
Yeah.
And of course, you get all the advantages that we already know for radial. Those patients really love to go radial. And when we started, many patients had both accesses. Some angios were performed through femoral and some radial. And after trying both, they really want to do radial. It's an outpatient thing. They just get out of the room, and in 2 hours, we were improving the protocols.
Yeah.
At the beginning, we started the cardiology protocols. It was 4 hours.
Yeah.
That's why I learned from them.
Yes.
And now we are diminishing as I think we are all trying to do, and with the new techniques that are coming. So I think it's a really convenient thing. And nowadays, for diagnostic, I think it's radial first. We are using 4 or 5 French, it's enough. You don't need, it's the main concern, the size of the tools you need, but for the diagnostic, it's okay.
Yeah.
And as we are radiologists, and we have the advantage to at least have some skills with ultrasound. You always can measure the artery, and most of the times you can do it. And also, recently, we have also moved to do the distal, which I think it's an advantage as well.
So you're doing distal as well?
Yes.
Yeah.
It's true that most of the time, if we're talking about diagnostic, we work from the right.
Yes.
We don't find the advantage as interventional radiology to do it from the right, but from the left, but we still do it. And also, it's not that common, but in some interventions, you need both accesses.
Yeah.
So in this case, it's really convenient to use the left distal.
Yeah. So you do. The majority of your cases in the neuro space, you would use the right radial.
Yes.
Yeah.
Most of them. Yes. Most of them. The only advice for that. So our success, I think we have improved. Our main difficulty sometimes is if you enter from the right to get the left vertebral.
Yeah.
Okay. But at least angiography you can do it. You always can place the catheter in the subclavia, or it may take more time, but it's possible. If you want to do an intervention from the left vertebral, in this case, of course, the advice would be to enter the left radial. That's the only thing. But most of the times we are using the right.
Yeah.
Yes.
Yeah.
And with the use of ultrasound, it has been easier for us to move from the forearm or conventional radial puncture to the distal.
To distal.
Yes.
Yeah. I mean, I think some of the points you raised with regards to where to start in the neuro space are critical. I think it's like anything. A lot of neurointerventionists, well, the first question they ask is, how do I do a 4-vessel angio? And I think the fact that you started off with 1 vessel, you picked a patient who had previous angiogram, you were doing a check for an aneurysm, and so they had 1 vessel to cannulate. I think it's a really, really good piece of advice. Start with 1 easy vessel. You're not having to spend, a lot of time trying to do a 4-vessel angio, and just work yourself up to the point where you can do a 4 or a 6-vessel angio using. When you say a 4 or 6-vessel angio, are you using the same catheter for the entire case, or do you have to change out, or are there any specific shapes that work better for certain vessels?
Normally, using Simon's 2, you can do everything. For Simon's 2. Sometimes Simon's 1 also works, especially for right carotid. And sometimes if I have to do an intervention, I use a Simon's 1 if it's in the right. But normally the workhorse catheter is a Simon's 2. Mm-hmm. The only changes that you may need sometimes is, as I said before, for the left vertebral. And these sometimes a longer catheter may help, like a Simon's 3. And sometimes, if we are talking about the left vertebral, almost all the times, it's possible to put the guide wire in the left vertebral.
Okay.
But sometimes, that's at least, maybe sometimes not, but it's really common. You can do that. Sometimes you encounter difficulties when you want to push up the catheter. And even you use a stiff guide wire, the catheter in the aortic arch, it falls down.
Yeah.
So just changing the angulation and using a cover catheter, sometimes it might help. That's the only thing. But normally with Simon's 2, I would say it's possible to do almost everything.
Yeah.
Yeah. Sometimes, if you have a lot of tortuosity, you can use a stiff guide wire.
Yeah.
That's the only main thing that you can use to have more support to put the catheter up. That's the main thing. In a technical point of view, if we are talking about diagnostic, yes.
Yeah. So I'm going to come on to treating stroke in a minute, but just because we've come on to the topic of stroke, it's one of the topics that I probably get asked on more than almost anything else by interventional radiologists in terms of, how do you justify the stroke risk doing a procedure, for example, where you wouldn't normally cross the aortic arch, for example, often working in the pelvis for fibroid embolization, or working in the liver where you often may not cross the arch. How do you justify to a patient the stroke risk? And I know, at least in my experience, I tell patients that it's a risk, but it's by far and away an asymptomatic stroke risk, and the numbers are small. We have lots of data from cardiology that have looked at stroke. As a neurointerventionist, how worried should we be, and do you think there's any specific precautions we should be taking to try and decrease the risk of stroke, knowing that we probably only crossing the left vertebral artery? Is there anything specifically we should be doing, or is it something that's probably overemphasized by interventional radiologists in general?
I agree with you that it's a main concern, doing stroke, especially if you're going, a fibroid or this, of course. But as you said before, the literature, the numbers are really, really low. And I think you're doing a very good thing. You're doing most of the procedure going from the left, ready for intervention. I think it's a good thing. For example, if we need to do a spinal angio, I try to do it from the left for the advantage of not crossing the arch. When we do a diagnostic angiography or neuroangiography, we have a risk of a stroke. It's quite low, but we have, and it's important, the bubbles. But it's difficult to say, but if you are punctured from the right and crossing the arches, as soon as while you are crossing, take care of the bubbles. You don't have any bubbles on it, and just once the catheter is in the descending aorta, I think it should be fine. Maybe another good thing, of course, you're having a catheter there for some time. At the end, we are using heparin because of the radial access. Probably this also helps, right? And as you said before, sometimes, as you said before, when we first started, we just were using 2,000 units heparin. And some of the neuro, for example, this SAH, the patient with no aneurysm, we were scared of giving heparin. But every time we are more prone to give heparin, and now we raise from 2,000 to 4,000 units. I think this is a good practice as well.
Yeah, it's interesting. Damon and you have said as well that you've increased your dose of heparin. Just out of interest, what's your dose of heparin? What are you giving?
So we've moved to 4,000 as well.
Did you start with 2 as well? Or?
We started, 2, 3, but we moved very quickly to 4. And so the literature supports that 4,000 is quite a reasonable dose to start off with. The rationale for starting lower is that you can increase. So with catheter exchanges, etc., you can move on to 3 or 4. But we just found that starting off with 4, by the time you get down, within the procedure, if you did need to increase with catheter exchange to 5,000 or 6,000, I don't think that increases the risk very much.
Yeah, and again, I think it's a good point. There was a study that came out a year or so ago, the Artemis trial, which looked at low and high dose heparin, 50 versus 100 units per kilo. In the cardiology space, didn't show any difference in terms of hematoma. And our practice is exactly the same. We started at 2,000. We were giving 2,000 units of heparin for many, many years. And we moved to a weight-based heparin dose, so we give 50 units per kilo, and it works out for the average patient 3,000-4,000 units. And then I also used to top up after 90 minutes with 2,000 units. I now top up every hour. And I think one of the things that I've also become more confident with is just giving lots of heparin. It doesn't make a difference in terms of your hematoma rate, but what it does potentially do is it decreases your radial artery occlusion rate, and especially in your patients who are at risk, your patients where they've got significant atherosclerosis and thrombus in the subclavian artery. I think if you're giving that more heparin, as you say, we haven't got data on it, but theoretically it would probably decrease the risk of stroke. And there have been some documented strokes in the radials in interventional radiology. I think if you critically look at those patients, a lot of them were probably underdosed with heparin. Of everything that was done in the procedure, probably the one thing that was pervasive in all these patients is the fact that they were not given a lot of heparin. And so I'm in the same boat. I think 4,000 units of heparin topping up every hour or so is an absolute minimum. And so we moved away from a very low dose of heparin, because if you're going to give it, you might as well give enough that's going to decrease your complications. So just talking about stroke, stroke is very topical. SIR have just published their guidelines on treatment of stroke, and Again, these are high-risk patients. These are patients who can't afford to have access site bleeds, especially after you've treated them for stroke because of the risk of hypotension and all the risks that go with it. And so, at least in my opinion, I think that subset of patients are ones that potentially could benefit from radial access, similar to the cardiology patients where they cannot tolerate an access site bleed because of all the major adverse cardiac events that can potentially happen. So, two questions, I guess. One is, are you using a radial access in your stroke population, and how do you pre-select patients?
So regarding stroke, surprisingly, now we are using it, but when we started, before doing stroke, I think it's good to do elective cases. I mean, there's one thing in stroke, you don't want to lose time. If you go radial, you need to be sure that you are better or as fast as doing through femoral. So probably it's not the way to learn or to start. So I think the learning curve, of course, is doing the diagnostic angiographies, then move to scheduled interventions that at the end, it might be easier because you just need to catheterize one vessel. And when you're really confident, I think it's time to move to stroke. And how we started with stroke, we didn't do radial first cases stroke. The first cases we made, it was after failure of femoral access.
Interesting.
So I was still frightened. Okay, you are confident with radial, but I'm risking, I don't want to invent things or risk time. So you go through femoral, and it's fun because I think we've done around 33 strokes. I reviewed not long ago. And the first cases were done after a failure of femoral access.
Interesting.
And after half an hour, 40 minutes that we were not able, then we moved through radial. But we could make it. So we don't have cases the other way around. And now after the learning curve, now sometimes we do it radial first. Now it's because we know that we will be faster. And in stroke, we review the CTA. So for type 3 arches, these elongations, surprisingly, we have found that radial can be even faster than femoral. The main concern there is the diameter, so you're using larger devices, sorry. So it's the radial diameter. So sometimes we check. Sometimes even I see the CTA, and before the patient comes to the room, I go to see the patient just to, I don't have an ultrasound there, I would like to have it, just palpate. If the artery is quite good, okay, let's go. And first of all, we measure the artery. If it's good enough, a type 3 arch, 93-year-old female, we go radial first. But I think it has to be step by step. And surprisingly, we have found out that in those patients with tortuous anatomy and depends on the arch, radial can be quite fast and be as good as femoral and a good alternative.
I mean, it's interesting that you went the other way around and actually you started doing your radial cases because of femoral failures. But I mean, it's a real thing, and I think a lot of people, particularly where potentially you're not doing a lot of oncology work or work where radial is so favorable, people will say, well, why should I start doing radial? And I think you've just highlighted the fact that you should do it because it's another access site. And you do fail at femoral. You can have really, really bad iliac disease, aortic occlusions, where you have no option but to go radial. And I think, again, those are not the cases to start on. You want to have done some nice, easy elective cases. So, you spoke about having comfort and being able to treat the stroke as quick as possible. And I know it's probably a difficult question, but what number, how many cases do you feel like you need to have done before you can do stroke, or you should do stroke? Do you think there is a number, or?
It's difficult to say. I think it's important to be honest to yourself at the end, and not just only yourself. What I think it's important, maybe you can feel successful, but you have to realize if your team is prepared to do that fast. I mean, there's some preparation. If your team in the daily basis is done to do a radial access, then it will be fast. Then it's a good moment. But you have to be sure. And I think there's a lot of cases that you will know before doing a stroke if this is a good anatomy or not. The problem, in my point of view, is when an institution never does radial and then after a femoral failure goes to radial. Then, of course, it will be more difficult. The room setup, everything will take longer. And if it's after a failure of a femoral, okay, try it. But as you just pointed out, as it's an alternative route, why not try it? Why not learn in elective cases and then use it in stroke?
Yeah, and I think it's a great point. I think the worst thing you can do with anything is to do it infrequently. So, there are lots of people who, when I talk to them, I'll say, how do you incorporate radial into your practice? Well, I do femoral most of the time, and every so often, if a patient I feel is suitable for radial, I'll do radial. But it's not really the way to work, and I think both of you have highlighted that. It's one of these things where you should just do it, get comfortable with doing it, and then, if you have a patient where you have to decide femoral or radial, you can do it. But I think to cherry pick cases and do, one a month, and then suddenly you get into a difficult situation where you almost have to use radial, then to having to start with a team who's unfamiliar with the room setup, you who are unfamiliar with how to do things in a stressful situation, I think it just, you immediately put yourself at a disadvantage.